The first development occurred almost 2 decades ago, with our group developing a bioartificial kidney with renal tubule progenitor cells, as demonstrated in this schematic. On the left side is a synthetic hemofilter used with continuous renal replacement type of therapy, directing itself to a second cartridge, which includes renal tubule progenitor cells from human cadaveric kidneys that could not be used for transplantation. The cells were grown along the intraluminal space, and blood was directed to the extracapillary space of the second cartridge to provide oxygen and nutrients to provide full renal replacement therapy in patients with acute kidney injury requiring dialytic intervention. After successful phase 1/2 and phase 2 trials, a phase 2 randomized control trial was done and demonstrated, as shown in this slide, a significant reduction of renal tubule assist device therapy in the dotted lines compared to control groups. And there was interest in pursuing eventually a phase 3 trial. Phase 2B trial was done intermediately after a licensing agreement and a cell manufacturing GMP process was established. But the requirement by the licensee required two major changes in the clinical protocol. One, to have a sham device without cells, and second, to include citrate anticoagulation as well as systemic heparin. Patients were treated initially with systemic heparin in the first phase 2 trial, but there was a suggestion of increasing the marketability of this device by allowing citrate anticoagulation to be used. There is a deep discussion of whether that should be allowed by the scientific advisory board because the effect of calcium in terms of cell function of the renal tubule cells and the potential loss of efficacy. This was initiated despite those objections, and after about at an interim analysis, after 50% of the patients were enrolled, there was a loss of efficacy of the renal tubule assist device, and post hoc analysis demonstrated in the sham group without cells a major difference in terms of citrate versus systemic heparin in terms of a 90-day and 180-day mortality rate. As demonstrated here, citrate anticoagulation with the sham device had a 75% survival rate versus a 25% and 180 days of the untreated controls. So that analysis of this serendipitous discovery was undertaken, and it suggests that the SCD, now the sham device with citrate anticoagulation, seemed to have a major effect on leukocyte circulating function. The SCD, similar to a hemofilter with a blood path on the external fibers, develops a low shear force environment for the blood interaction with the fibers, and the low ionized calcium increases the selectivity for most activated cells without causing increased activation. As demonstrated here in the light micrographs, with increasing power, you could see that what was binding on the outside of the membranes were nucleated white cells, and further evaluation demonstrated about 70% neutrophils, 20% monocytes, and no lymphocytes. So it was selective for activated monocytes and activated neutrophils. Further analysis demonstrated that in fact, the selectivity of binding on panel A of neutrophils and monocytes were due to the activation of calcium-dependent integrins along the surface of the hollow fibers. In the low ionized calcium environment, neutrophils was moved to an apoptotic pathway, whereas the monocytes were deactivated and moved to a less inflammatory phenotype, both of which being released back to the systemic circulation. This would allow to have an immunomodulatory effect without immunosuppression. That was the basis of multi-organ failure due to neutrophil sludging, poor tissue perfusion, leukocyte tissue infiltration with subsequent toxic tissue injury by release of various toxin products of the infiltrating leukocytes within tissue.